Okay, we're ready for our next presentation. Dr. Raghuram is an assistant professor in the Department of Internal Medicine, the Division of Infectious Diseases at the University of Louisville. She's also the Associate Fellowship Program Director in Infectious Disease Program, and she is the Medical Director of the 550 Clinic in the HIV program. She has a Certificate of Knowledge in Clinical Tropical Medicine and Hygiene, awarded by the American Society of Tropical Medicine Hygiene. She has done many poster presentations around HIV, community-acquired infections, and on health conditions that affect the refugee population in Kentucky. And she has had many articles published. We would like to welcome Dr. Raghuram.
Hello, everyone. It's great to be here. We're going to do a review on HIV and pregnancy, focusing on mom and baby. I'm not a pediatrician, so some of you know that part more than I do, but we will get on with our objectives for today. So today we're going to actually discuss the epidemiology and pathogenesis of HIV infection during pregnancy. We're going to discuss the impact of HIV infection on maternal and fetal health, and review the treatment strategies for HIV-positive mothers and their newborns, and also discuss some of the available resources for local assistance and referral for HIV care for moms and babies. I do not have any disclosures, and I just put up a quick glossary of terms. You're going to see some of these abbreviations over there. When you see MTCT, that means mother-to-child transmission. ART is antiretroviral therapy, HIV medication. Viral load is sometimes abbreviated as VL. Of course, you all know what HIV is. And PROM is premature rupture of membranes. So let's start with a case. So let's pretend this is Amy, and she's 19 years old. She is now 10 weeks pregnant, and she says, my HIV test came back positive, and I'm here in your clinic. So she's there at my 550 clinic. So she has a lot of questions. One of the questions is, how many people out there are HIV positive, and are there a lot of pregnant women that are living with HIV? Is this something that you all know what to do with, right? The other question, which is the most important question usually for most of our moms, is how can I protect my baby? They also want to know, do I need a C-section, or can I have a vaginal delivery? And questions after birth come up. Can I breastfeed? And mostly just, where can I get help for this? So let's start with the first question. How many people out there are out there with HIV? So this is a map from WHO, and you can see the extent of this epidemic. I'm going to apologize to the folks on this side because I'm going to point here because it's easier for me. So you can see some of the areas in red, those are the areas of higher density of infection. Of course, you can see in the Americas, it's a moderate intensity. We're talking about 3,400,000 people in the Americas. So this is truly a pandemic. For those of you who prefer numbers, hard numbers, you can see here the total number of people living with HIV in 2015. You see 36.7 million, and you'd get the breakdown in adults, women, and children. And newly infected also, a total of 2.1 million newly infected. And deaths, you can see here, a total of 1.1 million deaths. So this is a serious problem. And you can see that it's affecting all ages, and we see this in clinic every day. In terms of our next question, which was, are there a lot of pregnant women living with HIV? So here we have a graph, and you're going to see the red line here is actually the number of women who are pregnant and on therapy, all right? And if you look at the number here, looks like a big number, right? 1,100,000. That's a big number, but the blue line here is actually the women who are pregnant with HIV and who are not on therapy, and that's an even bigger number. So you can see there's a gap, and there's a true need to emphasize treating moms early because you prevent transmission to the child, all right? And moving right along, this is a graph about how starting antiretroviral therapy in moms has helped decrease that risk. So basically, if you look at the years, if you start in 2005 year, you had a prevention of 41,000 transmissions. And as you move down here to 2013, you can see that number is a lot bigger. So definitely this is a strategy that works, okay? And here in the United States, we still see this as a disease of disparities. You can see here that the rate of perinatally acquired HIV per 100,000 live births still remains much higher in the African American population as compared to the Hispanic and the white population. So that is something to keep in mind. It is still a disease of disparity, and we have to be very cognizant of that fact. The next question Amy had was, how can I protect my baby? That's the biggest question our moms have. So when we talk to Amy of how to protect your baby, we have to understand what is the risk of transmission during pregnancy. So let's kind of explore that a little bit. So here you see a graph, and this is, we're going to divide the transmission in different stages. So you're going to see here in utero infection, so while baby's still inside, the rate of transmission is about 30%, okay? And what are the mechanisms for this transmission? So you're going to have microtransfusions between mom and baby, placental breakdown, and also chorioamnionitis can contribute to this, all right? The prevention for this is, of course, early maternal diagnosis. If you don't diagnose mom, you're not going to know, and therapy for mom, okay? So that's the biggest thing for today's talk is early diagnosis, which means you have to think of it, and it is part of prenatal care, but we have to be sure that these tests are being done on moms, even if they're not pregnant, right? Before they get pregnant. Okay, so moving on to perinatal transmission. So the rate of transmission is the greatest in this phase. So the rate of transmission here is the 50%. And the mechanisms are basically contact of the infant with mucous membranes and bodily fluids and blood. And the greater than 4 hours of ruptured membranes has been described in the past as being associated with a greater risk of transmission. And again, prevention strategies here will be therapy for mom, C-section with appropriate indications, and also therapy for baby. In postnatal infection, the rate of transmission here is about 20%, and here it's contact again of infant with mucous membranes, and the biggest factor here is breastfeeding. So the prevention for that is no breastfeeding, and we will explore that in a little bit more detail right down the road. So as far as treatment for mothers, how do we approach the mother? Because that's who I mainly see when they come to clinic. So first of all, we talked about early maternal diagnosis being key. Most of the time for the patients that come to me, they've been diagnosed. Somebody has tested them. It's part of prenatal care, and they come to me with the diagnosis. However, it's important to emphasize that you should retest moms with risk factors during pregnancy. So most of you probably already do this, but you test in the first trimester and then probably later on in pregnancy. I've had a couple of cases where mom was tested early in pregnancy, was negative, however, didn't know her partner was positive, partner was on meds, did not disclose that information, was not compliant with meds. But so if you look at her, well, I'm married, stable relationship, monogamous, no risk factors. However, there was this other side story that she did not know, and she actually got acute infection during pregnancy. Baby was infected, but there was no retest at the 3rd trimester or 2nd trimester. So this went undiagnosed until baby was 8 months old, and now she's feeling sick, and then workup happens, and lo and behold, you have a positive HIV test. So it's very important to know that the concept of what is a risk factor is not just risky behavior. You know, having sex is a risk factor. It's a general recommendation. If you're age 16 to 64, you're supposed to get tested once in a lifetime if you've had sex, okay? So that is very important, and that's something you should be tuned into when you're seeing these moms for prenatal care. For moms, they should be started on combination therapy, 3-drug therapy. We have a whole arsenal at our disposal in the clinic, the 550 clinic. We have pharmacists that work with us. We work very hard to be able to provide mom with a regimen that's going to be simple, that's going to be safe in pregnancy, and that we're going to try and control side effects, nausea relief, timing of taking that medication. This is a whole process, but starting that therapy is essential, and as soon as possible. Sometimes you might see people advocate for delaying therapy till the 2nd trimester because in the 1st trimester they're already nauseated and they probably won't be compliant, but you should truly start as soon as possible. And as of 2012, there's been a shift in the guidelines. For a very long time, depending on the patient's counts, we would watch and wait. From 2012 onwards, the recommendation is you start upon diagnosis. So that's also important to know that there's been this shift in treatment for everybody, not just pregnant women. So every single person, the recommendation is you start treatment upon diagnosis. You don't wait for their CD4 to fall to X, Y, or Z. You don't wait for their viral load to be X, Y, and Z. You are offering treatment for these patients as soon as possible because they will do better. And you should, we talked about starting maternal therapy early. We already talked about that. And we should do baseline resistance testing because it gives me an idea of what medications work for this patient. That is important as well, but that should not delay my starting the therapy because it takes 3 weeks for that test to come back. I don't necessarily have to wait 3 weeks to start my therapy. We have a pretty good idea of what is gonna work, and we can always simplify or modify when we get that result back, okay? But we should have the baseline testing. That's my bad. And for my moms, I usually follow them up in clinic every 3 months at the minimum. It's very tailored to each mom and what her needs are. I might see them every 2 months. When they're getting close to delivery, I will even see them each month because I want to try and get that viral load as close to the delivery time so that you guys who are going to deliver these babies and going to take care of the moms when they're giving birth have the most recent viral load, okay? And again, this goes hand in hand with what I just said. Monitor the HIV viral load very closely because that has implications in mode of delivery, which we're going to talk about. And of course, all these moms should have high-risk OB follow-up, okay? Now, that is the treatment for mothers, and when we start, we keep going even after delivery, lifelong, as of now until we find a cure, okay? For babies, and my peds colleagues and neos here know this better than I do, so for the treatment for exposed babies, you should initiate between 6 to 12 hours, and all exposed babies should have the AZT, and the duration of this prophylaxis, as you will be from birth to 6 weeks. If mom was very well controlled and you have no concerns that she's about non-compliance with her HIV meds, that can be shortened to 4 weeks. Most likely you're gonna do this up to 6 weeks. Now, if mom didn't receive treatment or prophylaxis, then they add a second drug called nevirapine, and that is a 3-dose thing for the second drug, and at 48 hours, then at intervals of 48 hours. So that is the treatment for exposed babies. And how do you follow these babies? At the beginning, if you just do a regular antibody test on this baby very early on, that antibody is not really reflective of baby's infection because it takes time to build up antibodies, so that's actually mom's. So that's not gonna give you too much information. So you should actually test for the RNA PCR, which basically measures copies of virus in the blood. And you can do this at birth if it's a high-risk baby with a positive mom, for example, who didn't take medicine or wasn't compliant, or if mom's status is unknown. But typically you do it between 14 to 21 days, then 1 to 2 months, and 4 to 6 months. And you want to time it a little bit after they finish that 6 weeks of prophylaxis if they're on it, okay? And eventually you can close the case and say baby's not infected if they have these negative tests at these time periods. So basically, if you have 2 negative viral load tests measuring the copies of virus in the baby at more than a month of age or more than 4 months of age. So if you have 2 negatives, then they're considered not infected. If you have 2 negative antibody tests, now remember, baby's going to take longer to make its own antibodies, so that is a longer time interval, so more than 6 months of age at 2 separate specimens. If you have 2 negative antibody tests, then you're okay. And some experts recommend doing that antibody test again at about 12 to 18 months of age, just to kind of really close the case. All right. So now the next thing we're going to explore is the impact of HIV, both in maternal and fetal health. And for that, we're going to have to explore how the virus actually infects you and what it does to you. Okay, so we're going to talk very briefly about the HIV pathogenesis. So we all know that the main thing that the HIV attacks is your CD4 cell. Eventually what happens is that virus is going to store itself in lymph tissue, so in lymph nodes, and that's going to lead to massive viremia within days and weeks, and you're going to have trapping of this virus, and you're going to actually then move on to a very chronic infection. Now this virus, basically your immune system is trying to fight it off, and it holds it at bay for a certain amount of time, because we all know that this doesn't happen over days and months. This actually happens through weeks and months and years. So this is a very long process. So your body fights this as much as it can, but eventually something's got to give and your immune system takes the hit. So if we explore what happens in children, as far as clinical manifestations, if they're undiagnosed and not on treatment, you're going to see lymphadenopathy, because that's where the virus likes to stay. You're also going to affect other organs, so liver and spleen can be enlarged. You can see thrush in advanced cases, failure to thrive, a developmental delay. HIV does like your central nervous system, and it likes to stay in your brain, and so it does lead to neurocognitive impairment. And not just in kids, in adults as well. And of course you have your traditional AIDS-defining illnesses, fungal infections of the lungs with the pneumocystis, other recurrent infections, CMV, candidiasis, and encephalopathy. Now in terms of mom, what are some of the things that you can see in the adults? So this is truly a very systemic disease. We think of it as just, infections, you're going to not be able to fight off infections. But in fact, there's a whole spectrum of disease, including, so you can have increased risk for malignancy, so leukemias, lymphomas, any malignancy actually. The nervous system, we talked about how it likes to stay in the brain, so you can have neuropathy, you can have dementia from HIV. So that's something that I see in clinic as well. It can affect your GI tract, give you diarrhea, can affect your bone health, thyroid. It can increase your glucose tolerance, so you have a whole host of different things. It can also affect your cardiovascular system. So high cholesterol is something that we try to monitor very closely in clinic, and it can induce then risk factors for hypertension and heart disease. And it can also have effects on your bones, so osteoporosis is something else we kind of try to keep a track of, okay? So this is truly a multi-organ disease. So now that we've explored the clinical manifestations, let's go to the next question Amy had. So Amy was asking, will I need a C-section? So what is the recommendation for that? So this is the DHHS guidelines as far as interventions to reduce transmission. And basically what they say is if you have a viral load, mom has viral load of more than 1,000, or you don't know the viral load near delivery, then you should schedule a pre-labor C-section at about 38 weeks. And this strategy has been found to minimize the risk of transmission. And in these cases, you should add intrapartum AZT. Now, if mom is really well controlled and her viral load is less than 1,000 copies, then in that case, you can go for your vaginal delivery, and the risk of mother-to-child transmission is very low. And in this case, it's unclear that there's a benefit of actually adding on AZT during delivery, because some of my moms are very, very well controlled. Their viral loads are undetectable, which for us is 20 or less. So there's no real added benefit of giving them IV AZT during the delivery, okay? And so what happens though if before you can actually get to your C-section, you have premature rupture of membranes? So what happens then is an individualized approach. So you're gonna have your expert consultation, and there is also a hotline that has been helpful if you're in a pinch, and you can call this hotline that can come up with a strategy for you at this time. And, but usually it will obviously depend on what kind of follow-up mom has had, what were her last numbers. It will depend on a lot of things. So there's no real set cookie cutter form for this, but you just have to figure out what to do with expert consultation and the hotline, which is helpful. And what are things you should avoid, you should avoid during delivery, unless of course there's a clear obstetric indication for this, but anything that's going to increase your baby's contact with bodily fluids from mom should be avoided. So you should not rupture membranes artificially. You should avoid fetal scalp electrodes, forceps, vacuum extraction, and episiotomy, unless there is a obstetric indication for this. We're not saying, oh, don't do this ever. If you need to do it, you have to do it, but if you can avoid it, try to, all right? So the next question that Amy had was, can I breastfeed? So here is a graph concerning the difference between transmission in formula-fed infants and in breastfed infants. So if you look at the formula-fed infant, so let's kind of break this down. So if you have a formula-fed baby, the overall risk of transmission, if you don't have treatment, mom's not on treatment, is 15 to 25%. So let's say we have 100 moms, about 15 of them are going to transmit to their babies if they're not on treatment. And of those 15 moms, what is the overall, like what's the breakdown of where transmission happens? So here you can see during pregnancy, it's about 25 to 35% the transmission happens here. And you can see it divided in early pregnancy, 20 to 25%, and most of it happening in later in pregnancy. And the intrapartum period is the biggest transmission risk. So 65 to 75% of these moms here will transmit during this period. Of course, since these little guys are formula fed, you don't have the third part here. So here you see the breastfed infants, and here you have a little bit of a different graph, because the overall risk of transmission for these moms, if they're not being treated, is greater, 25 to 40%, because you have an added step for transmission. So of these moms here, in this portion that you see breastfeeding, is 25 to 45% of the transmission happens right here. In labor and delivery, 35 to 50%. So that's a big chunk. So because of these data, there's been a recommendation to try and avoid breastfeeding. And we'll go into that a little bit more, because this differs if you're in a resource-limited setting as opposed to a resource-rich setting. So for WHO, these are their two recommendations. You either avoid breastfeeding and you provide alternate sources of safe nutrition for baby, or you're going to provide breastfeeding and provide ART for the breastfeeding moms, okay? So you can see that there's two different and opposing strategies, and this has to do with the socioeconomic conditions, because in Africa, for example, if you don't have access to safe nutrition or formula or clean water, that is going to be a bigger risk to your baby as opposed to breastfeeding. So in that case, you're going to promote breastfeeding, kind of weighing risks and benefits, and you're going to try and provide the best maternal therapy to decrease transmission, all right? And of course, here in the United States, the recommendation is the opposite, because here we do have access to safe nutrition, formula, and water for the babies. So here, the recommendation is you are going to avoid breastfeeding. Mom still needs to be on medicine, and you're going to provide safe nutrition for the baby, okay? And this is just a summary of all that we just said. And these are recommendations for the United States, and basically, pregnant moms are going to start antiretroviral therapy lifelong, and for the baby, of course, they're going to be on formula. They're going to receive their prophylaxis from birth to 6 weeks, and then they're going to obviously get their testing. And if they're HIV infected, truly, you have to link baby into care, of course. Hopefully, they're already linked into care. And on this other side is for resource limited places, and that is the difference, that the breastfeeding is going to happen. You still have to link mom and baby to care. And I do want to say that in the US, the overall risk of transmission from mom to baby is as low as 1 to 2% because moms are getting treated, okay? All right, and then the last question Amy had was, where can I get help? So what are your resources here in Kentuckiana? So I kind of lifted these resources from the Kentuckiana AIDS Alliance. They have a really nice directory of resources. So there's several different things I wanted to point out to you, because this is not just the clinical part of care. We also have several different aspects and layers to care. So they do have Camp Heart to Heart, which is for a summer camp for kids. We do work closely with the Clark County Health Department across the river, because we do have mutual patients, so they are engaged in getting those patients connected to care, and there are caseworkers there through the Clark County Health Department. There is legal aid as well, and I left all the numbers there for you to peruse. House of Ruth provides housing for and support for HIV-positive moms, also folks with addiction issues, and so that's another resource. Of course, the Metro Public Health and Wellness, they do STD testing. There's a fee of $20 for those. There's also prevention programs associated to the health department, a syringe exchange program, and you have numbers included in the slide. And the 550 clinic is where I am. We do have a care coordination program to help these moms with all their needs, their social needs. And of course, we have the medical clinical side of this, which is our providers. Currently, we have about 2,000 patients total in our clinic, which is a pretty large clinic. As far as pregnant moms, we've been fairly successful. We've seen an influx of moms also with the outbreak in Scott County related to IV drug use. We've had some moms come in through that too. And we work closely with our OBs. As soon as we get the diagnosis and they are coming in to us for care, we hook them up to OB. And sometimes it comes the other way around. OB has tested them and then they come to us, but that needs to be a very close relationship. And of course, as I said before, we're trying to do those viral loads as close to delivery as possible so you have the most accurate data. For the most part, my moms are usually compliant, but some of them fall off the wagon. They're doing really well in the beginning, and then they kind of stop taking their medicines. That's why I kind of pull them in a little, at less frequent intervals so that I can keep a really close eye on them, because I don't want that risk to be there. And there's a lot of talking and counseling and what happens when I am going to have the baby, what do I do? So we kind of explored all that through this talk. We also work with the School of Dentistry. They do see our patients for their dental needs. And Volunteers of America also works with prevention. And so those are the most important resources that you need to know in terms of our local resources. So in summary, we saw that HIV has a significant global impact, and that HIV in pregnancy has consequences for both moms and babies, and is still a disease of disparities. And early maternal diagnosis and treatment is really key here. and close follow-up of moms and their babies. This all requires engagement in care, and those efforts are always ongoing, and that's probably the toughest part of our job, is getting them engaged in care. Because I tell all my patients, if you take this medicine, you're going to be just fine. Your life expectancy will be 79 years of age, but getting them to that point is usually the challenge, and that is what we do every day. I think that's all I have for you. If you have any questions, thank you very much.
Does anyone have questions? Yes, we have one over here. My question, wings clinic versus 550 clinic, are they the same thing?
Yes, okay, I should have opened with that. Wings was our old name, and we changed it to the 550 clinic because we did a poll with our patients, and there were several options on the ballot, and they picked 550 clinic because it's on 550 South Jackson, and that's why it's called the 550 clinic. But yes, they're the same thing, and a lot of times I'm on the phone and I'll say, I'm calling from the 550 clinic, formerly Wings Clinic, but it's the same thing.